Welcome everybody, and thanks for joining us in our presentation on the Ranas approach to systematic behavior change in humanitarian settings. We brought to you 3 different case studies of how we use the Ranas approach in different humanitarian settings in Mozambique, in Zimbabwe, and in Bangladesh. Before we then want to discuss or present first to you 3 adaptations of the approach to the humanitarian settings, and of course we are happy in welcoming your feedback and the discussion. The Ranas approach in its traditional way is adaptable to very different settings and contexts, to different behaviors, not only in the WASH sector, but also to other protective or risk reductive behaviors. The Ranas approach is evidence-based, so we use the data, the information from our population that we want to work with. So it's also population tailored, and it's ideally always evaluated. Our understanding of behavior change is that we provide our target population with a certain promotion campaign or with a certain behavior change information, and we expect behavior change. But there's of course this individual, this person in between this process, and we want to understand what guides this person, what are the thoughts, the beliefs, the feelings related to the new target behavior. So we say that the behavior change starts in the heads of people, in the mindsets, and this is what we try to understand by applying the Ranas approach. What you can see here is the Ranas model, and in the core of the model, in the blue boxes, you will find the behavioral factors, which represent the mindset of our target population, the thoughts and beliefs. We classify them into 5 different factor blocks. We have the risk factors, representing the knowledge of a certain health risk, the attitude factors, the beliefs about costs and benefits, and the related feelings of a new target behavior. We have the social norms and the ability factors, which represents the knowledge of how to execute the behavior, and also the confidence about always performing the behavior. And we have the self-regulation factors, the knowledge about when, where, and how to perform the behavior, and how to overcome certain barriers. These behavioral factors are embedded in the context, the social, physical, and personal context of our target population. The unique aspect of the Ranas approach is that for each of the factor blocks that you can see here in the blue boxes, we have different techniques, behavior change techniques, to tackle them, to change them. These are represented in the Ranas approach. And the outcome, of course, in the violet boxes are the new desired behavior. And with this, I hand over to Max to take us to Zimbabwe for our first case study.
Thank you very much, Anna. I would now like to take you to the Tongogara refugee camp in Zimbabwe, where we designed and implemented a campaign to promote handwashing and physical distancing that used posters and church meetings and household visits, and was very much focusing on creating social norms and the perception of approval by others to promote these 2 target behaviors. We evaluated the campaign using a controlled design, implementing it first in some areas of the camp, then doing our evaluation, and then implementing it in other areas. And here you can see the results with regard to tippy-tap construction. And we can see that in 94% of households in the Ranas group, we could observe tippy-taps, self-constructed tippy-taps at our follow-up survey as compared to just 8% in the comparison group. And we can see that in 52%, that's the bottom line here, we can see that in 52% of the Ranas households, there was soap and water at the tippy-tap as compared to 4%. So we see much more functioning tippy-taps in the Ranas groups. And here we can see the results with regard to physical distancing. You can see the different key situations on the horizontal axis, and the changes of physical distancing from the baseline to the end line. And we see that on average, physical distancing increased by 16% in the Ranas intervention areas.
Thank you, Max, for your insights from Zimbabwe. And I will take you now to Cox's Bazar in Bangladesh, where we implemented a Ranas behavior change project together with UNICEF and 11 partners from the WASH sector on 13 different health and environmental behaviors. In Cox's Bazar, there's one of the largest refugee camps with a population from Myanmar. Approximately 800,000 people live in very condensed conditions, and here is where our project was located. Here you can see the timeline of our project in Cox's Bazar. So it all started in April 2019 with several qualitative interviews or the qualitative survey on all different behaviors to understand the context of the behaviors in the camps. We used the outcomes of the qualitative survey to develop the quantitative survey, which then was implemented in May to August 2019 in more than 5,000 households. We assessed information on the behavioral factors, on the Ranas factors and the behavior, and the outcome of this quantitative survey was then used to develop behavior change campaigns for each of the selected behaviors. Then the campaigns were implemented, and you know what happened then. We had to stop everything due to the COVID-19 pandemic, and we did our first follow-up only in July 2020, still on only 4 target behaviors, because those were the ones that were still implemented, like handwashing, for example. And then the other activities continued, and we had our final evaluation in October 2020. This is one example of the results of our campaign from the final evaluation. So on the left side, you see what we implemented, different behavior change techniques to target different factors, vulnerability, shame and disgust under the attitudes, and remembering. And we managed to change those factors. And the behavior that we tried to change in this example was the drinking of chlorinated water, and we achieved an increase of 43% of habitual drinking of chlorinated water. And with this, I hand over to you, Anna.
One of the prototypes to adopt the Ranas approach to the needs of the humanitarian settings is using the Ranas method in a pure qualitative way. This qualitative approach has been applied in northeast Nigeria, where regular cholera outbreaks occur. The tool has been tested in a host community in Borno State. After discussion with a partner organization that works in this community, handwashing with soap and water has been selected as target behavior. Our key question to answer was, how can we motivate people to perform more handwashing with soap and water at key times? In total, 6 qualitative interviews have been conducted. 3 qualitative interviews were done with doers, meaning with respondents who do often practice handwashing with soap and water, and 3 qualitative interviews have been done with non-doers, meaning with respondents who do not often practice handwashing with soap and water. Due to the small sample size, the results have to be interpreted with caution and they cannot be generalized. Nevertheless, tendencies have become visible and they were in line with existing findings in handwashing research. This has been the tool that we applied, and the items written in black letters were the items where we found differences between doers and non-doers. For example, we found differences for the items: what are your positive feelings toward handwashing with soap and water? What do you like about handwashing with soap and water? What do you think others in your family or your neighborhood do in regards to handwashing with soap and water? And do you see any barriers or problems to perform handwashing with soap and water? All items from the qualitative tool can be related to the Ranas behavioral factors. So, for example, we found that not having a designated place for handwashing, using a kettle and storing the soap distant to the water source affect people's confidence in performance and their confidence in continuation. Also, feelings were connected with hand washing with soap and water performance, mainly having positive feeling towards hand washing with soap and water. Others' behavior should be tackled as well to change the hand washing with soap and water frequency of non-doers. And soap not being always available can be connected to the factor barrier planning or coping with barriers. Each behavioral factor of the Ranas model is associated with one or more behavior change techniques. And the matching behavior change techniques can be implemented as either a standalone activity or as a part of an existing activity.
I would now like to present the second prototype of adapting the Ranas approach for humanitarian contexts. And here we would structure it into four different phases. First is a check of preconditions, whether behavioral interventions make sense at all. For example, by checking the behavioral, infrastructural, or even organizational preconditions. If this shows that a hand washing or behavioral intervention would make sense, we move on into a measurement of the Ranas factors and of behavior through a ready-made questionnaire, which would then be automatically analyzed, for example, through a tool like the Kobo Toolbox Excel Data Analyzer or Power BI. So the data would be generated and directly and automatically analyzed. And this would then give us the difference between the doers and the non-doers, and thereby identify the behavioral factors that the intervention should focus on. So this means that this approach is data-driven and evidence-based. And now, depending on the results of this analysis and the behavioral factors that have come out, we will use an activity catalog with off-the-shelf activities for all Ranas factors, and we would select those activities which match the behavioral factors that have come out of the analysis step. So thereby, we would reduce the workload a lot, because there would be no sophisticated design required and no skills for data analysis, and at the same time maintain the population tailoring and data-driven approach.
So this is the third prototype that we want to present, Ranas for acute emergency response. So we're talking about a very special context with very limited resources on all sides. The prototype here is that we offer a ready-to-use behavior change activity catalog, so a step-by-step guideline for certain activities, but only for priority behaviors, so for example, for drinking chlorinated water. The activities would need no or only little adaptation to the context, and would also be very limited in terms of that there would be activities for each of the 5 factor blocks. And optional would be to evaluate the acceptability of the users. This prototype would not need much preparation, so it would be very quick and would not need much resources. The campaign would still be theory grounded, because the activities are based on psychological theory, and every activity is already validated. What the campaign would not offer is that it's population tailored, so based on evidence or data collected within the target population, and it would not be evaluated.